Thanks for that kind introduction and invitation to speak to you all. I should have probably changed my slides because when I arrived here today, I was inundated with questions about what the Innovation Initiative is, and I won't be speaking about that, but I'm going to be around all afternoon, and I'm happy to catch you in the breaks or afterwards in the social hour, and I can tell you a little bit more about that one-on-one. Today I'm going to, I guess this is how I drive this. No, maybe not. Yeah, I'm going to talk about convergence of drugs and devices. Strangely, this is a title of my career because I'm an engineer. I've never taken a biology class, but I've started 3 pharmaceutical companies, so go figure. And partly I learned all this by working with experts, some of which are in the room, and that really helped me guide my career into making medical products. And I've always come at it from an engineering perspective. But what you'll find in my talk is that you discover new biology this way. And it'll come up at a couple of points in my discussion, and particularly around drug delivery in single compartments, which is what I like to say I specialize in. So single compartment drug therapies, rather than trying to design the molecule to be targeted to the site, we physically get the drug to that site. And what you'll find, what we've observed, is not only does it do what you thought, but it actually does disease modification in many cases, and I'll show you what that is. So the first example I'm going to use is chemotherapy targeted at the peritoneum. So diseases like ovarian cancer, which is this one's described as, or any type of peritoneal metastasis or other types of cancers. One of the ways that this is treated, in fact, in the ovarian cancer case, for high-grade carcinoma, they will actually deliver the chemotherapy directly to the peritoneum. So every 6 weeks, the patient is hooked up to 2 liters of fluid. They fill the peritoneum. They turn the patient over to try and wash their body from the inside with the chemotherapy. Because after debulking, which is the first procedure, cytoreductive surgery, there is still a few cancer cells left. And that's where the recurrence comes from. There's an indwelling catheter that's, I guess, sorry, this doesn't have a pointer. There's an indwelling catheter that's placed there, and that's a problem that creates infections, catheter blockages, toxicity from the high-dose chemotherapy is, of course, they do these instantaneous, very high doses of cisplatin, and you get delivery of the drug to the systemic circulation. Most of these patients do not get all 6 cycles because this therapy is too toxic. So what are people doing now? So here's a great example of delivery of drugs to a single compartment, and it is proven to be effective. So what's being done now, interestingly, this is taken off outside of the US. It's only now coming here because this past month, New England Journal article pointed the benefit of this. But what's done now is they do, after cytoreductive therapy, they flow fluid, warm fluid with cisplatin in it, through the peritoneum and through this machine here, this device. And this is done once. That's only indicated once. But you'll see the benefit of that in the next slide, I think. Here it is here. So this is for women that have had very high levels of tumor burden when they presented at the doctor for the physician. They had so much tumor burden that they had to have 3 neoadjuvant systemic cycles of chemotherapeutic, in this case carboplatin. And then what's done is they use this HIPEC procedure, and what you see here is that survival 5-year survival is twice that of the control group. So these are the worst of the worst, and this actually had a huge impact on their survival rate. So what are we doing about it? Well, remember I said this is just a one-time shot. We know that the benefit is actually derived from multiple exposures in the standard of care case, at least in the United States. So one of the ideas is to actually make a sheet of material like shown like this that releases the drug over an extended period of time. So you do the HIPEC, and then through the laparoscopy tube, push a sheet like this through and it deliver over an extended period of time. And I'll come to the next example. I think it's the next example. We'll show you why I think that's can have an impact. And this is one of the companies I started. It's called Taurus Biomedical. They're here in Lexington. They were doing what they were trying to do is do single compartment delivery to the bladder. There's a whole number of indications. Whoops. Yeah, there it is. So the first they worked on was an inflammatory bladder disease. They now have programs in bladder cancer and overactive bladder. The basis of the technology is this. It's built on a medical procedure. So this is the connection to the procedure. In this case, it's a catheterization. So there's a catheter, and the device is inside that catheter. You catheterize the patient, you push the device out, and then it ends up looking like this pretzel-like device in the bladder. The most common urological procedure is catheterization. And the second most common is what's called cystoscopy. It looks like a catheter, except it has a scope on it. Thousands of these are done just in MGH every year. A very, very simple procedure. So this device sits in the bladder, releases drug over a period of time, and then is removed by cystoscopy sometime later. So this was their foray into muscle-invasive bladder cancer. It was reported a year ago. Was their first study. Muscle-invasive bladder cancer is half of those patients get their bladder removed. And the other half, oh, actually, my friend, I see one of the co-inventors in the audience, Hee-Jin Lee. I didn't know you would be here, so I should give him credit. Really great. So these patients that get this muscle-invasive disease, half of them get their bladder removed. And in many cases, that's actually curative, but of course, it's life-altering. And I'm going to come in a second to the other half of those patients. But these patients in this study had tumors of at least 3 centimeters in size. As I said, they were muscle-invasive, which puts them in the T2 or T3 categorization. This device released gemcitabine. Two systems were placed in sequentially with a rest period in between. And all the patients that were involved in this study were cystectomy eligible. So after we did this, we're going to get their bladders removed. The next slide is kind of an eye chart. It's a small study, 10 patients. But the interesting thing about this, if you look down here, the response rate is huge, right? So over half these things had either no residual disease. Remember, this started as a 3 centimeter tumor. All these patients got the same dose. 4 of them had total ablation of the tumors. All the rest of them were downstaged except for 1. And most importantly is this last column, and this is what I mean by new pharmacology, is that when they do this surgery, it's very invasive. It's many hours long. They not only take the bladder, they take all the draining lymph nodes, which are 50 lymph nodes, and they do histology, pathology in every one of those. And in these patients, well more than half are usually positive for cancer. None of these, except for 1 patient, was positive for disseminated disease. And that really started to start us down the path of thinking that we're actually doing disease modification. And what we're actually doing is immunizing these patients. So we kill this one tumor with no drug exposure anywhere else in the body. And of course, we preserve the immune system, and so we built a vaccine for the cancer. And so you see the effects disseminated. And after this, they did the same thing in a preclinical model and showed that it actually works. So what about the other patients? Half the patients get their bladder removed. What happens to the other half? Those folks are too sick to get the surgery, or I was really sad to hear that many of them decide, even though they may be eligible for the surgery, they decide not to get it because of the consequence of living a life without a bladder. And it's a very, so we think we have something to offer those patients now. And it may be that we can go to this, and in fact, our study is now enrolled, almost fully enrolled, in the cystectomy ineligible patient population. By the way, I didn't mention the life expectancy for that other half that is around 9 months. So it's a pretty a devastating disease. Next project is stone disease. So we're already in the bladder. What about going to the ureter? So as you know, kidney stones, what happens there is that a stone produced in the kidney actually gets caught in the ureter 90% of the time. And that stone causes the ureter to start to spasm. It's actually peristalsis. If you ever had a kidney stone, the pain you're feeling is that peristalsis that's happening. And we're talking about, the burden is huge. Now, fortunately, people tend to not die of this. If it gets stuck too long, there are surgical procedures that they can do. But the general thing is, if it's less than 10 millimeters in size, 5 millimeters in size or so, they're going to just say, why don't you take some off-label drug for prostate treatments, and maybe it'll relax the ureter. It's proven not to work, but they give you this, and just hope, drink a lot of water, and hopefully it's past the stone. So we took a look at this and said, what if we were to deliver the drug directly to the ureter? And the first question is, what drug? And so we deployed high-throughput screening methodology. We grew ureteral cells from 5 donor ureters, human donor ureters. We screened a large panel of drugs for their action on these in this in vitro culture. We then took that and did ex vivo studies on pig ureters, so you can harvest the ureter. It's still actually alive, and we could then expose those to drug. And then most recently, we did this to in vivo studies on pigs that will be hopefully published soon. And the basic idea is shown here, is that you can use a cystoscope, which is shown there on the left, go through the urethra into the bladder, and then up into the ureter, and inject the formulation. Of course, this is a formulation that's designed for retention. And what you see there in the middle is the pulse, what happens when you do this. So these are pressure waves from the ureter. Oral tamsulosin is the oral drug that's done. You can see it doesn't really do much, but when you instill the drug into the ureter, it completely knocks out the pulsation. And really, it's that needs to, what happens is the stone gets caught there, it swells closed, and then it's trying to do this. And so by relaxing the ureter, you can stop this process from happening. And then the last one is slightly different. This is a drug delivery to a single compartment, but this is now the tumor compartment. And this is you might, at the end, you'll realize that this is a diagnostic. It's not really a drug delivery device. But I will say that probably the next wave of drug delivery technologies is going to be single compartment delivery to tumors. The concept that I described in the TARIS device of immunizing the patient against cancer by treating a tumor is spreading throughout the industry. I think that's, you're going to see that in more and more immuno-oncology studies. So this is Ollie Jonas's project. He was a postdoc in Bob Mai's lab, and I continue to work with him. He's at Brigham and Women's right now as a scientist, staff scientist there. But what we do here is we put a device into the tumor. So this is done basically with a biopsy needle. And the role of the device is to deliver drug, but not just one drug, many drugs. You'll see we typically do 18 drugs at a time. And the idea is you leave it there for 24 hours, and it's such a small amount of drug, it only diffuses a small distance away from the origin in the side of the device. And you can come back and take a biopsy and then section the biopsy and stain it for apoptosis, and you know how that tumor reacted to each one of those drugs. So it's drug sensitivity testing. And so this gives you an idea of the sequence. Of course, we make these tiny devices. You can see there we're machining some in a block. The second image over there on the top is one of the devices. You can see we've essentially machined holes in the side of it. We've micro-injected different drugs into each one of those holes. And then you can see here it's a tumor and a flank of an animal. And what we do is we put multiple devices into that. So if each one of those devices is carrying a different drug or different drugs in each reservoir, we can rapidly, we've actually done 200 different drugs in a single animal and looked and evaluated the sensitivity to all of those. Of course, there's sections taken, like you see there. They're put in a big block. Now we're doing sort of high throughput histology and embedded in wax, and then finally end up a slide. We're doing a project with the Mayo Clinic. They have over 200 PDXs there. We have 40 drugs that we're testing across each one of those PDXs. The computational time to review all those is just huge. So we're looking at the phenotypic response of each one of those PDXs, patient-derived xenografts, to every drug that we have in our panel, which is 40. And so you get the histology slide. It's stained there. You can see it's stained for cleaved caspase 9, which is that dark region around the device. You then use image analysis to count the cells. We look at background, which is the green area versus the active area, and that gives us an idea of the activity. And here is just sort of a validation of it. So on the left, it shows the apoptotic index, which is a measure of reaction for this particular tumor against a short panel of drugs that you could, so that you can see all these effects here. And then we, for the same cell line, we did systemic exposure, and you see they rank order in exactly the same way. So what we've learned from the Mayo project, which is interesting enough, that it's very difficult to predict how a tumor will react to targeted agents, doing things like gene expression or something like that. Most of the physicians, reason why they wanted us to help them there at the Mayo Clinic was simply because those techniques do not predict with confidence how a patient will respond to a targeted drug. So that gave you, I think I'm pretty much on time, but I wanted to allow some time for questions. In every case that we looked at, in fact, Heejin, if you grab him at the break, he can tell you also that just how amazing it is to continuously release drug into a single compartment and actually change the pharmacology. So get different responses, elicit an immune response. As an example, we've seen examples. In fact, one that was published was when we delivered lidocaine to inflammatory bladder cases, what we found was we thought we were going to be treating the symptoms, but what we found in some cases, in fact, the very first cases happened to be patients with visible lesions in their bladder. And those lesions went away. The investigators noted that when they removed, their symptoms improved. We removed the device. The urologist says, notes in their records, the lesions disappeared. And interestingly enough, we removed the lidocaine, and the benefit accrued over weeks and months afterwards. So the patient benefited after we removed the drug. So this is clearly not a pharmacology that was obvious just based on what you know about lidocaine. Well, it turns out there's a huge literature on lidocaine on its anti-inflammatory properties. And so I wish we were smart enough to know that ahead of time, but that really changed the whole focus of the program to be disease modification as opposed to treating patients. So I think I'll end there and take some questions. Thanks.
I got a mic for you.
Yeah, oh, sorry.
So the last study that you mentioned, was that used to sort of interrogate different areas of the tumor? So you could, with the last study with this microdosing.
Yeah, we've done the same device in multiple areas of the tumor.
Exactly, yeah.
And it's interesting, the most recent observations I have are all these huge amount of data that we've done at the Mayo Clinic. And in fact, I was just reviewing some new batch this morning. And you do see variability in the response. And it seems like the variability is greater for drugs that are cell cycle dependent, which was the first hint that what was going on. So doxorubicin is a great example of that. And so if you go from one point to another in the tumor, its vascularization is different. The cells in that region are replicating at different rates. The toxicity of the same exposure to the drug is different from point to point. It's amazing because drugs that are not, like targeted agents that are not spent, they give you a tighter distribution than the ones that are cell cycle dependent.
Great talk, thanks.
Yeah.
Hi, great talk. Over
Sorry.
here.
Oh, over there, sorry.
Hello.
Thanks.
Very cool to see new technologies in developing more frontiers fighting cancer. But one of the biggest challenge, I think, would be delivering to the brain. Did you try anything related to slow release into tumors area in the brain?
Yeah. So yeah, that's something I have been involved. Bob Langer and I have been involved in for a long time, and Bob longer than I have. So it depends on the indication, right? So if it's glioblastoma, basically the conclusion that most people have come to now is that the cancer, you can't really treat one area of the brain. You have to treat the whole brain. And really, those cancers appear to be have less mutational burden than a lot of others, like lung cancer, for example, or melanoma or something like that. And so, ovarian cancer is very similar to that. The mutational burden in ovarian cancer is much smaller than other cancers. And the response to immuno-oncology agents seems to be inverse to the, just very hand-waving here, seems to be inverse to the mutational burden that they have. So high mutational burden means they respond better to immuno-oncology drugs than others. So ovarian cancer does not respond to known immuno-oncology agents. To date, the same problem exists for glioblastoma. So why is that? And what could you do about it? And that's kind of this bladder cancer study, I think, is one. gives the hint, and I know in other cases that people are starting to look this way, is that if I can use an existing tumor and treat an existing tumor to make it generate a vaccine, that may be the new approach. So delivery to the brain then might not require that you deliver everywhere. You just deliver to one location and elicit an immune response. You would create an adaptive immune response to that cancer everywhere in the brain. So still local delivery may become important in glioblastoma, but it remains to be seen. Nobody knows how to do that little trick that I described there, but that's an active area of research, is exactly to do that. Other areas of treating CNS diseases, I think, are really interesting because before I started partnering with Anne Grabiel at MIT, quite frankly, I sort of knew there were compartments of the brain, but it was sort of a layman's view of it. And what I now realize from working with her in the past 7 years is that there's a lot of compartments to the brain, and they're a lot smaller than you think. Regions that are a cubic millimeter in size. And it turns out that, or less in some cases, and it turns out that many diseases of the brain are not, or CNS diseases are not everywhere in the brain. So like mood disorders. These are sort of pathology, a circuit pathology that involves just certain loci. Another one would be epilepsy. So like over half of epileptic patients have a focal disease. So there's a small region of the brain that's generating this. But only a small fraction of them will benefit from surgery. The morbidity from the surgery is, so to actually resect that. So could you go and target that small region with a cannula, really small cannula, and deliver drug, a very small amount of drug, just to that region of the brain? So what's not in here, it was one of the things I was considering doing is, like, what if I had a cannula that was 60 microns of diameter? And it turns out those cannulas, first off, they are what I call microinvasive because there is no, we leave them in the animal for a year, and the amount of scarring that goes around it, we call it gliosis in the brain, is imperceptibly small. And even more interesting to me, which it reminds me of Heejin's project, is that the students started saying, sticking a 60 micron, this is like a hair, sticking a 60 micron fiber into a brain over 10 centimeters deep. And you can do it. There's a trick to it, but you can push it right in. So if you go through the skull and open up the dura, there with a 2 millimeter hole, it's called a burr hole that they do. It's a very simple procedure. You can go right and address multiple sections of the brain. And hemorrhaging, the other thing is interesting, is hemorrhaging is not a problem because the needle can go right through an artery and come right back out, and it doesn't bleed because it's so small. It just closes right back up. It's too small of a incision. Until you try these crazy things, you don't realize that you can do them. And so that's an area I think could grow a lot because now we take these very invasive surgeries and turn them into what I would call a micro-invasive surgery and get the drug to where it needs to be. So sorry, that's a long-winded answer, but I think it's a new area for drug delivery research. Yep.
So I would like you to speculate a little bit. Do you think that the compartmentalized delivery technique could change the paradigm of treating prostate cancer away from surgery and towards more of an oncological technique?
Yeah, so back to starting a clinical trial. We're making the clinical supplies right now, and hopefully the first patient in will be in July. Now, those patients will be cervical cancer patients, but for high-dose brachytherapy, which is for sort of cases that are inoperable, the worst cases, Same procedure is done for cervical cancer as for prostate cancer. And those are done under MRI guidance. That's just the standard of care. So there's an MRI in the OR. And what's done is in the cervical cancer case, which will be our first patient, they put 24 catheters into the tumor under MR guidance. And then the patient goes into the next room, and they put the radioisotope down the catheter, and they're basically, instead of delivering drug, they're delivering radiation intratumorally from point to point. They're painting the inside of the tumor with radiation. Now, why do I bring this up? Well, it turns out that most tumors are hypoxic. They have low oxygen tension. And this has been known since the days of Warburg in the 20s or 30s or something like that. And it turns out the appropriate radiation dose depends on how hypoxic the tumor is. And they don't know it now in any given patient. So they're always up against this. Well, we don't want to do too much because we might get and it's known, it's been proved that if you get the higher radiation dose, it actually improves survival. So we're putting a material at the end of that catheter that when you image it in the MRI, it tells you the oxygen tension. So it's not really drug delivery, it's radiation delivery, but it's intratumoral, it's a procedure, and we're enabling the better use of that radiation because for each one of those catheters at each point in the tumor, you'll know what the oxygen tension is or oxygen pressure is at each point. Okay, how am I doing on time here? I don't want to overstay my welcome.
Okay, one more.
Okay, one more.
Michael, would you care to comment on the whole issue of data analytics and the genomic code in the treatment of cancer? In a real sense of, you put my interest and you talked about ovarian cancer. I had a family member that went through a clinical trial for Taxol before it was synthesized. But we made great strides. Back then it was, I thought, the impression I got is oncologists were just going with experience and got filling us full of radiation and chemotherapy. And my sister got 5 years to the human clinical, but obviously it was stage 4 and too late. But data analytics today, the sharing of data and that whole genomics and looking at past treatments and what might work better, not only would we save money in terms of treatment, whether it be chemotherapy or radiation, in targeting in a certain way or whatever, but also would it really look to expand, lifetime of, lifetime and also maybe cures. So it's a big thing now that wasn't around, and how does it play a role here?
Well, I mentioned, why are we working with the Mayo Clinic? And the Mayo Clinic has like I said, has this very large PDX collection, cell collection. And it's because gene expression profiling of individual patients has not yet proven sufficiently accurate for clinicians to dose the myriad of drugs that they have available now. And so while we're testing these PDXs in animals, the hope is that we could actually stick one of these devices into a patient, leave it there for 24 hours, minimally invasive procedure, come back the next day, remove that tissue, minimally invasive procedure, do the histology, and see how that tumor reacted to 18 different drugs. And now it's a phenotypic description of that patient's tumor. So there's two ways to look at this, is that can I see actually how that tumor responds to drug and compare that to the gene expression profile and see, can I convince myself that, yeah, it makes sense, this targeted agent, and we've revealed that in these, some of these targeted agents randomly in the tumors we looked at have exceptionally high responses, but they're one of 50 different things that the oncologist has available to them. How do you define that? And strikingly, in that case, the gene expression profile didn't predict that that was going to be the one that was responded the most. So we're not there yet, actually in the clinic. What is the single largest determinant of ovarian cancer outcomes is the success of surgery. The more that tumor that they can remove at the surgery, the cytoreduction surgery, the greater chance the patient has to survive. It's still, if you don't have a good surgeon, it doesn't matter what drug you take. Okay, thanks.